Good afternoon, everyone. My name is Brittany Starks. I'm Communications Coordinator with Debbie Stream Foundation, and I want to thank everyone for joining us for our webinar this afternoon. Before we begin, I'd like to thank some of our sponsors for this event. Our title sponsor, Merck, Platinum sponsors, Astellas, Daiichi Sankyo, and Zymeworks, Gold sponsor, Bristol Myers Squibb, and Bronze sponsor, Seagen. During today's webinar, you can type your questions throughout the presentation into the chat section that appears in the webinar menu. We will address questions after the presentation as time allows. And I will now introduce today's moderator, Dr. Jordan Berlin. As Associate Director for Clinical Research at Vanderbilt-Ingram Cancer Center, Dr. Berlin directs the development and conduct of clinical trials of new drugs across all diseases, including gastric cancer. In his role as co-principal investigator of the VIC GI SPORE grant, he helps translate laboratory findings into clinical trials that promise to improve the outcomes of patients with GI cancers. Dr. Berlin also serves as a member of DDF's Scientific and Medical Advisory Board. Dr. Berlin, welcome, and thank you for joining us today.
Thank you, Brittany. Good morning or afternoon, everyone. My name is Jordan Berlin. I'll be moderating today's discussion. I'd like to take just a few minutes to introduce the other panelists. First up on our panel is Dr. Yelena Janjigian, medical oncologist at Memorial Sloan Kettering Cancer Center. She also serves as principal investigator on several clinical trials and MSK and is a Debbie's Dream Scientific and Medical Advisory Board member. She kept her intro paragraph very modest. She is a spectacular researcher specializing in gastroesophageal cancers. Also joining us is Dr. Madhapa Kundranda, Director of GI Cancer Program and Chief of the Section of Medical Oncology at Banner MD Anderson Cancer Center. Dr. Kundranda is also the principal investigator on several clinical trials at Banner MD Anderson through several organizations, including ASCO, AACR, Pancreatic Cancer Research Network, and the Cholangiocarcinoma Foundation. And rounding out our panel is Dr. Timmy Nguyen. Dr. Nguyen joined Cleveland Clinic, Florida in 2001 as a board-certified medical oncologist. His special medical interests include anal cancer, bile duct cancer, colorectal cancer, esophageal cancers, and gallbladder cancer. Today, we're going to be discussing the latest updates on clinical trials and hearing from the experts on what options are currently available. The last 10 minutes of the webinar will be set aside to answer your questions. So we're going to get started with Dr. Janjigian presenting slides.
Thanks so much. I'm just sorry about that. I was trying to figure out how to turn my camera on my phone and failed. So today is a pleasure to discuss some of the trials that really changed practice this year for treatment of both esophageal and gastric cancer. As Dr. Berlin mentioned, I'm a medical oncologist and chief of GI oncology service at Memorial Sloan Kettering. It's been a pleasure to be able to lead some of these studies that really changed practice for our patients. Next slide. These are my disclosures and funding information. Next slide. So what we'll briefly discuss today and take questions on is how immunotherapy transformed treatment for our disease. Immunotherapy is a class of drugs that's been in development for many years, and this year we had 3 breakthrough approvals, particularly for immunotherapy in combination with HER2-directed therapy. And we'll talk a little bit about molecular features that affect response and inform treatment selection. Next slide. So CheckMate 649 is one of the studies that really changed practice, especially for first-line patients. When we say first-line patients, what we mean is that it's a patient who presented to their physician, was diagnosed with cancer, and has not had any prior treatment for their disease. Typically, this involved cases where the cancer is either advanced to the point where surgery is not possible, or it's metastatic where it's involving other organs. So CheckMate 649 enrolled patients all over the world, and patients were enrolled whether or not they had this biomarker in their tumor called PD-L1. PD-L1 is a test that your doctors check on your tumor And patients also were enrolled only if their tumor was known or they were excluded if the tumors were HER2 positive. As you can see, this was a large study, global effort. Majority of the patients were actually enrolled outside of Asia, which is unusual for these type of studies because historically stomach cancer, since it's much bigger problem in Asia, where it's as common there as we have colon or lung cancer in the US, in Asia, most of the studies, show that the Asian gastric cancer is slightly different than the US stomach cancer. And so therefore, it was very important to do a study that enrolled patients mostly outside of Asia. And what other interesting point about the study is that it included patients with adenocarcinoma of the esophagus and the GE junction. So this is the spot between the esophagus and the stomach, or in the earlier part of the stomach, where actually most of our patients in our practice present. Stomach cancer in the later part or the bottom part of the stomach, again, is a different types of cancer. In the US, we have increased rate of these proximal stomach cancers, which is actually, we see, I mean, in my clinic, it feels like there's a increasing number. Certainly the data suggests that as well, of especially patients, young patients, patients under 50 presenting with this disease. So it was a critical study to do because over 2,000 patients were randomized. People received standard treatment with chemotherapy that we all are used to giving in clinic, which is FOLFOX. Then patients received nivolumab plus FOLFOX. And then there was a third arm that looked at nivolumab, ipilimumab, which is the chemotherapy-free arm. So the first two arms already read out a year, and we had at least a year follow-up. And this was already published in one of the big cancer journals called The Lancet, because the primary endpoints were all met for the first two arms, the nivo chemo versus chemo. And then at the big cancer meeting in Europe and Paris this just past weekend, I presented the results for the 2-year follow-up, so the long-term follow-up. For us to be able to report on 2-year follow-up in stomach cancer is really already a game changer, because this is the disease where people typically, don't do as well in first-line setting. And then we presented the results of also the immunotherapy only backbone, the nivo ipi backbone, again with after 3-year follow-up, which was a secondary endpoint. Next slide. So CheckMate 649 already changed practice for metastatic disease. This was FDA approved in April of 2021 based on this large study looking at chemotherapy plus immunotherapy with nivolumab. On the left, you see the curves for the primary endpoint, which is what we call, this biomarker selected patients. When we say biomarker, we mean that there's a test that the patients get from their tumor from their pathology report, and it's called combined positivity score of 5. And it's a complicated test, but I think it's important for patients to be aware about it because it is very operator dependent. In other words, it really depends. If you put 10 pathologists in a room together and they all look at the same slide for CPS score, not all of them will agree. And in fact, most of them will disagree. And in these clinical trials, what we have is usually 1 or 2 really experienced pathologists who their full-time job is to look at these slides. So there's a lot of agreement and careful review. But in practice, what happens is when you get a CPS test, and your oncologist, if they're not really reading the fine print of how it was done, which antibody was used to do the test, there's a lot of pitfalls on the test results, particularly if it's a small biopsy, because the pathologist literally just sits in the room and counts the number of positive cells total in the biopsy, literally counts one by one, and then looks at the positive cells that are stained positive, both the cancer and non-cancer cells, and makes a calculation to come up with a CPS score. So what's important about this study is that it showed that overall survival improvement was regardless, so in all-comer population. And the reason why is because CPS 5 population was actually the highest proportion, was 60% of the patients were CPS 5 or higher, and 80% of patients were CPS 1 or higher. Next slide. And what we presented at ESMO is a long-term follow-up. You skipped one, go back. Yeah, what we presented is long-term follow-up results of the nivo chemo versus chemo. And again, at 2 years, there's still a nice separation of the curve. what the oncologists look at when they look at survival benefits is this thing called hazard ratio. It's a statistical test to see what % of patients actually benefit. And the hazard ratio actually improved over time directionally, meaning that it got smaller. A small number is good here. So anything that's smaller is better. And as you see here, the hazard ratio and the median survival, and I think it's always scary to look at the median survivals in these studies, and I don't want my patients to memorize these numbers because they don't reflect the survival of patients in tertiary cancer centers and the survival of younger patients. And if you remember on CheckMate 649, very few patients, only 40% actually went on to get any additional treatment. Again, reflecting the global practice patterns. These patients were treated in Chile and Russia and all over the world, not necessarily in America. In the US, in my experience, a lot more patients get second and third line therapy. Next slide. When we talk about the biomarker testing, it's critical to have your tumor tested for this test called MSI, which is also usually tested, is easily done by on your biopsy. And the MSI patients, we talked about the hazard ratio, remember, and the hazard ratio here of 0.38 is really groundbreaking because shows the importance of immunotherapy in first line setting, knowing what you're getting, especially if you don't have access to immunotherapy readily. It's particularly important to get it when you are getting, if you have MSI high tumors, because there the survival curves really separate even with a 2-year follow-up, as you see here on the left. Next slide. What about immunotherapy only? What can we forget about chemo in our disease? And the bottom line is the answer is no. We need chemotherapy. Looking at Nivo-1, Ipi-3, Ipi is just another immunotherapy that's even more potentially toxic than nivolumab. The curves are separating in the beginning in favor of chemo. So if you don't get chemo in first-line setting, you may get into trouble because chemotherapy really works in that disease. It shrinks the cancer. It helps patients feel better and start eating and nutritionally improve. But what's interesting is that after a while, the immunotherapy curves do win out, and there is a separation after long term, but that separation wasn't big enough to ultimately show the benefit for immunotherapy. So you need chemotherapy in first line setting. Next slide. Well, what about response? What the data suggests that, it's interesting, if you do respond to Nivo-Ipi, and I see that in my practice all the time. In fact, the Nivo-Ipi arm here was based on the study that I did in 2013. And we see some patients who do respond, and some of them are, not even very high MSI or PD-L1. If you do respond, the duration of response is nearly doubled than that of chemotherapy. It's 6 months improvement. And so again, suggests that there's a population of patients that could really benefit from these drugs. Next slide. Particularly if you're MSI, the overall response rate for Nivo-Ipi cohort is 70% with MSI high tumors. The median survival is not reached. The curves really plateau. And in my practice, we cured some patients with stage 4 disease, which has really been one of the most transformative, experiences in my life. Next slide. So this is, again, to remind that all PD-L1 testing is not created equal. In the US, there's this entity called CLIA approval. So any CLIA approved test could be done interchangeably. It doesn't have to be the same antibody that was used in the study. And there's some variation in how pathologists interpret. And because of that, because of all these pitfalls, and because of the truth is, majority of the patients do have PD-L1 positive tumors, 80%. The FDA approved nivolumab irrespective of PD-L1 status because the PD-L1 testing is not as reliable by CPS, again, because of this inter-observer variability. And the truth is most patients are positive. I suspect, I certainly wasn't at the table during the FDA discussions, but I suspect that's what led to the FDA approval irrespective of PD-L1 status. Next slide. So this is a case of a patient, which, I wanted to just put in to give you some hope. And again, this is a pretty typical case in my clinic, a relatively young patient, previously very healthy, a woman with no prior medical history really, who presented with profound bloating and 25-pound weight loss, was found to have peritoneal carcinomatosis, which is a very typical way that our gastric cancers present in the clinic, particularly poorly differentiated gastric cancers. As you can see here, this is how the cancer usually looks under the microscope. It just these poorly differentiated sheets of cancer cells. On biomarker testing, her tumor was HER2 negative, and that's when you see your doctor, ask them what type of biomarkers were done in my case. Was HER2 done? Was PD-L1 done? Did you test my tumor for MSI? And we also now do NGS, next generation sequencing, on all tumors. And her cancer had a KRAS mutation, PI3 kinase alterations. It was not a well-behaving tumor. It was a pretty aggressive cancer. And satisfaction, with her was that after just first few doses of nivolumab and chemotherapy, she had near resolution of all of her symptoms. She started gaining weight. She was able to eat, which was for the first time very reassuring to her. Next slide. Next slide. Okay. And she received about 11 cycles of FOLFOX nivolumab. Oxaliplatin-related neuropathy is a barrier of how long we can keep these agents on. So oxaliplatin was discontinued. She continued on 5-FU nivolumab for 2 years, which is what we typically did on the study. In clinical practice, sometimes patients are very hesitant to stop immunotherapy, and that's totally understandable. It's a personal decision and a discussion with the patient. If the patient is doing fine, I typically continue it. And this woman in particular was continuing at capecitabine. I saw her just in clinic on Wednesday, actually, and she's approaching 3.5 years. And on endoscopy and just repeat PET scan and imaging, she has no evidence of cancer, which is, again, non-MSI tumor, potentially cured with stage 4 disease. These really game changers. Her tumor did have high PD-L1 expressing tumor, and I think that really helped her benefit to such duration and durable response. Next slide. MSI tumors, we know in particular, I won't belabor this point, but they're chemotherapy refractory. You must treat them with immunotherapy. Next slide. And now switching to HER2. HER2 is an important biomarker. Up to 20% of tumors in the stomach overexpress HER2. We had trastuzumab for over a decade, and after that, nothing else has worked better than first-line chemotherapy with trastuzumab. And the reason why is, unlike breast cancer, we tried T-DM1, we tried pertuzumab, lapatinib, all these drugs that are FDA approved in breast cancer, and it's because gastric cancer, unlike breast, HER2 is very important, and the doctors that tell you that HER2 is not as big of a target in gastric cancer are completely wrong. It is a huge target and important, and we've proven that. The problem is that with HER2 in gastric cancer, there's other parallel problems that occur because stomach cancer is different than breast cancer. So then they also have RAS and PI3 kinase and MET. So it's not the only issue. Gastric cancer is more complicated. Next slide. So what we did is combine immunotherapy, and this was, a long effort that we've developed these preclinical and clinical rationale for this phase 3 over a course of 5 years, and it was really culminated into this global phase 3 that we recently read out, Keynote 811. For those of you who participated in the study, many thanks. It brought this agents quickly to our patients because what we demonstrated, so the survival is the primary endpoint, but the next slide. What we were able to demonstrate early on, just at the first interim look, that the change in overall response rate was really dramatic with 23% improvement in overall response rate. The immunotherapy, other trials that I just showed you improved the response rate by 15%. So to have 23% overall response rate with excellent tolerability and no real additive toxicity impressed the FDA to the point where they already approved this combination in expedited fashion in May of this year. So in April, we had Nivo approval. In May, we had Pembro with trastuzumab approval. It was pretty good spring for our patients. And now this combination is already approved and available. If the study is done, hopefully in the very near future, we'll have the survival benefit. We're just waiting for the data to mature because these patients are living so long, and this will take a while to read out. Next slide. And then the last but not least is, what about after trastuzumab and pembrolizumab and other these things stop working? Well, in second line, we now have an option. The Destiny studies, Gastric 01 and 02, have both read out. trastuzumab deruxtecan is a antibody drug conjugate that is approved in breast cancer. In fact, there was recently a big study that compared to head to another ADC called TDM1, and TDXT was much better. In gastric, we have already approval in second line after trastuzumab failure. What I would recommend is definitely asking your doctor to have a biopsy to confirm that the tumor is still HER2 positive. And we just saw the results at the European Congress about the Destiny Gastric 02, which showed overall response rate and progression-free survival in second line. So after first line chemotherapy stops working, then patients go on this drug that is very similar to what we saw in Japan in third line. There were no new safety signals. I think it validates the approval. The risk with lung inflammation or something we call ILD is very important. So if you're on these drugs, you have to report to your doctor every little cough or shortness of breath symptom you have, even if you think it's unimportant. There were less serious events on the study than there were in the Asian population, I think because of the difference in the patient population. You know, in breast and lung, it shows that if you treat the patients earlier, in other words, before they're exposed to more drugs, the risk to the lung inflammation is less. But it's certainly a chemotherapy drug. It's not benign. So you have to watch out for nausea, take, you know, a lot of nausea medicines, and diarrhea can be a factor, and it can cause low blood counts. So that's, I think, all I have. Do you want to, right, and these are the survival and the response rates with this drug. Next slide. And where is the future going? Well, you know, we've made a lot of progress in stage 4 disease just because it's sort of where all the studies were, and in some ways, the studies read out quicker in stage 4 disease, right? Because you can look at response, you can look at patient survival. And the next wave of the studies that I'm working on and my colleagues are working on are really in bringing this early stage so that we don't wait for metastatic disease to develop before we cure patients. We already have some drugs available in adjuvant settings such as nivolumab, but what we think, and this is a complicated picture, but essentially what you should take away from it in the first bar is that while the cancer is in place and while you have these micrometastases, which is what ultimately can kill you if they set up shop in lung or liver and other organs, we need to expand the T cell population so that these T cells in your own body's immune system can suppress the micrometastasis. And the best way to do it is while the iron is still hot, meaning while the tumor is in place, and you know, while we can educate the immune system and show the, you know, what it needs to go after. So that's what we're doing. A lot of the trials is in perioperative neoadjuvant setting. Next slide. If you have the study open near you, please try to participate. It's an important study that looks at 3-drug chemotherapy combination with FLOT in combination with durvalumab, which is an anti-PD-L1, which is very similar to anti-PD-1 drugs. So this study is occurring nicely. We're already almost a third way done. It's also a global study. So we could definitely use your help because it will bring these drugs earlier to our patients quicker. I don't want to treat metastatic disease. I want to be able to treat early stage disease and tell patients they're cured. And certainly we've done that with subsets of metastatic disease, such as HER2, MSI, high PD-L1 expressing tumors, but it would be nicer to do it in more patients. And I think that's all I have. Thank you for your attention, and I'm happy to take any questions.
Thank you, Dr. Janjigian, for a nice run through of the recent advances. And you know, it is great to see that immune therapy has helped out a significant number of people. And as well, we've gotten some advances in the HER2. What do you think, you know, because there is that small group that doesn't seem to derive the benefit from the immune therapy, the CPS less than 1. Do you think that there's some more stuff on the horizon in that group as well?
Yeah, absolutely. And, you know, I get that question a lot, especially, you know, I think academically, if you have 100% certainty that your pathologist, you know, is giving you the right answer, you know, CPS less than 1 patients, which really represent only 18% of the population, benefit less. But the truth is the overall response rate, even in that population, is still improved with nivolumab. So until there's something else better out there, which I think there will be very soon, we're already working on 2 other options for those patients. Until there's something else better for those patients, in my practice, unless there's medical reasons not to give them immunotherapy, I still offer them immunotherapy. We're now looking at combination of other drugs. So learning from the HER2 space, where we know that targeting the cancer with cancer-specific agents, right, and then also augmenting the response with immunotherapy helps. It's like 1 + 1 = 3. There's some synergy. So that's what we're doing for HER2 negative space. There, it's a little trickier because in HER2 negative space, there's so many different targets. So we're just looking at different targets that could augment the immune response.
It's nice. There's something for everybody starting to come down the pike and more improvements. Do we have questions, Brittany?
Right now, one of our questions is, what are the pros and cons of being a part of a clinical trial?
So Dr. Kandranda, would you like to take that one?
Yeah, absolutely. Thank you, Dr. Berlin, and thank you, Dr. Youngin, for that excellent overview of the recent advances that we've had in the presented data. With regards to clinical trials, it's clearly the reason why, and I think some of it is actually sounding like a broken record, because like Dr. Youngin mentioned, for us to try to get some of these therapies which previously had taken about 5 to 10 years to come to the market, the reason why we managed to push the envelope in the last several years is because of the fact that we've had more patients enrolled on the clinical trials. However, clinical trials, I completely agree, aren't for everyone. So in that case, it needs to be weighed out between the pros and the cons. However, in the setting wherein the patients who do not have reasonable options, I would say, in the treatment setting, these are the patients that would certainly benefit from that. When you talk about the pros and cons of clinical research, one of the #1 pros is the potential of getting a drug that could help in your overall survival per se at an earlier stage, because if you wait till the drug is approved, that might be beyond the window where you could be treated. The second pro is some of these drugs, even though they're not FDA approved, tend to be used off-label. The problem with using drugs off-label on a regular basis, especially in the community, is the fact that it's not monitored at the same rigorous monitoring levels that we would do on a clinical trial. With regards to those are the 2 main pros that I can think of. With regards to the cons of, if you can really call it the cons of a clinical trial, one of the things that we are very cognizant of is just the patient preference. In some of these trials, especially the early phase trials, you might have multiple visits to the cancer center that might deal with issues. Some of my patients do deal with that. Some of my older patients have to wait on their rides, and then what we call the PK study or the pharmacokinetic studies, wherein they need to come multiple times during the course of the week. That is where this needs to be weighed out between the potential benefit that you can derive from it and the potential this inconvenience, I would say, that you would have from that. In addition to that, it's a new drug. Some of these early phase trials, we're still evaluating the toxicities. Most of the data that's been presented today has stuff wherein we already knew the safety data. So that is something to be cognizant of. Again, it's a personalized decision with the patient and the physician in terms of if a trial is appropriate for you. And the second question is, and then the second thing is, even if a trial is appropriate for you, are you in favor of going down that path of being on a clinical trial?
I have.
I can expand on that. I absolutely agree. I think it really depends on your comfort level with your physician and how well the trial is explained. I think in most patients' cases where the disease is incurable, the road to therapy is, needs to include both standard and experimental therapy to offer patients the most chances. And the longer you're doing well and the more treatment options you're getting, the higher the likelihood that while you're waiting, other new things will come up. So what I tell my patients is that those patients who trusted us and went on some of the studies that I just presented were able to get treatments 5 years ago that are only now available to as standard of care worldwide. So I think sometimes it's a risk and a leap of faith, and you have to really know what you're willing to endure. But and certainly trials can be inconvenient. You have to travel to certain locations. Sometimes they, in some ways you get more attention because the people, there may be sometimes a little more frequent visits or more blood work. But those are the ups and downs of it.
Dr. Nguyen, you had something you wanted to add?
Yeah, just one thing is that often patients are concerned that they go into clinical trial, they get a placebo or a sugar pill, and they go, "Oh, I'm going to travel that far to get a treatment I can get here if I'm going to get a placebo." See how do you, the panelists, address that issue? Because tell patients that occasionally there's crossover where the treatment works, then they will get the active drug, so they'll be first get access to it before everyone else if they participate in a clinical trial. Would that
Right.
be
Well,
accurate?
in cancer trials, it's rare that a placebo is used alone. If the most common use of placebo in a clinical trial for cancer is to give standard of care with an experimental drug or standard of care with a placebo, but it's rare that we use a placebo alone. So on almost all of our trials, I don't know, Elaine, if you've had any trials with placebo control in a long time. I haven't, but in almost all of our trials, everybody gets
Keynote 811 was placebo controlled, and it was a challenge because we already had our phase 2 data, right? And most of the patients and oncologists were convinced that this was going to be the regimen, and it was a challenge enrolling patients. And some of it is, sometimes you just need to realize that unless you participate in trials, and the truth is we don't know if the experimental arm is better, and you're at a minimum in these trials, you're getting standard of care. I had several patients that went on the study, and as a result, we had approval. So, and obviously the patients who were then randomized, well, first of all, a lot of times you do know what they're getting based on the side effect profile, but but then you're able to get the standard of care or better once the drugs are FDA approved. This is just part of being a cancer community. If you don't contribute to clinical trials, not only aren't you going to get better potentially, right, because there's not going to be new treatment options, but neither will the patients coming after you.
Well, yeah, and in Keynote 11, the standard of care at that time for those patients, there wasn't another option. It was either experimental drug
you have to design, exactly. You have to design a trial in a way that it's ethical, and that's critical to do.
So we never give less than what we would give off of a clinical trial is the bottom line.
Awesome. We do have another question that came in. A viewer asks, are all doctors getting tumors tested to determine the treatment? This person wants to know from each panelist at their institution. Does that make sense?
Get what tested?
Are all doctors getting tumors tested to determine the type of treatment needed?
So I think what they're talking about is an NGS testing. So Dr. Nguyen, why don't you start with this one?
Oh yeah, so we do the standard. It was a non-metastatic curable like MSI, but with metastatic testing, with metastatic cancer, with advanced cancer, then yes, we do the full next generation sequencing testing for everyone.
Yeah, I agree. I think one variation I see between institutions, and certainly between the commercially available assays such as Foundation, is NGS on the tumor is pretty standard now. What people are still not doing routinely is germline testing. So not just looking at your tumor DNA, but also looking at your DNA and trying to figure out why you developed cancer, especially if you're at a young age. And we are picking up, not in esophagus so much, but in stomach cancer, we are picking up some alterations that may have, one, implications for the treatment, even if they're germline, but two, certainly for the kids and the family members of the patient. So I would say that I see that most institutions, you know, when I see patients for second opinions and so on, are doing tumor testing because that's easier, and also there's a lot of send out labs that will do it. Germline testing, first of all, you know, some patients get nervous about it, but also there's different consenting and, you know, paperwork that has to do, so not everyone is doing it.
Right, and we do what's called NGS testing. Our NGS does a little bit of what we call germline, but we also refer to our genetics counselors. And the nice thing is a lot of institutions have their own genetics counselors. We also have geneticists, which are physicians trained in genetics. Unfortunately, I think there's a real shortage of geneticists in this country. And that's showing up now that we're recommending more and more people go for genetic testing. Dr. Condrando, what's your practice?
Yeah, I would completely agree with everything that's being said. And I think about 4 years ago or so, we were probably doing a limited panel. But since then, we pretty much in all advanced cases, we do the complete next-gen sequencing. And to Elena's point, yeah, we do the germline testing as well for exactly the small subset of patients where you can pick up certain actionable mutations, but also in the context of the genetic component of it. And most patients, for the most part, yeah, especially younger patients, do at least get that initial pass with the genetic counselor, especially when there's a higher risk that this could be a genetically driven tumor.
Yeah, I'll note that if you know, so anybody who gets a diagnosis of cancer, it's scary and there's a lot going on. It's also a good time to really talk to your family and find out what other cancers have developed. There are a lot of us who, you know, personally don't talk to a lot of my family very often. So, you know, knowing what other cancers may have developed may give the geneticists clues as to what they need to test. So it's always good to know your family history if you can. Not everybody can. Not everybody knows their family history. But.
Yeah, and if you have a MSI high tumor, this, you know, subset that I just talked to you about, it's important to get Lynch testing for germline Lynch. So even if they don't, you know, you don't have the extended germline testing available, at a minimum test for Lynch because these are Lynch associated cancers. And I've had patients in my clinic who, you know, presented with gastric cancer, and then upon further questioning, turns out their dad had colon cancer and many other cancers, and just never bothered to tell them, you know, or they died, you know, they were estranged, or, you know, so it does have implications to you and your family.
Right, and for those who are curious why she keeps saying Lynch, Lynch is a guy named Henry Lynch, not some horrible process that's been done in the past. It's Henry Lynch is a guy who described the syndrome for the first time, and that's why it's named that.
We have another question that came in. Have there been recent advances in treatments for patients with CDH1 mutation?
Good question. I'm not aware of any. Elena or Tim or Dappa?
Yeah, so, you know, CDH1 germline enzymatic alterations happen more often in signet ring cell type tumors. And I would say the biggest advancement for signet ring in general is this discovery of the claudin 18.2 protein, although it's not only in signet ring cell tumors. The signet ring cell tumors appears to also have overexpression of that.
Right.
And at this part, this last ESMO, I would say one of the most interesting first looks, and you know, again, at the risk of igniting all of these requests, you know, there was a CAR T cell therapy trial that looked promising in 11 patients. So small study coming out of Asia. It was a Chinese company presenting the data. So it's claudin in general may be a small step forward, particularly for signet ring cell tumors, not specifically for CDH1 alterations. Remember, CDH1 is a tumor suppressor gene. It's not an oncogene, so it's not all that druggable in itself.
Yeah, and just so people know what that means, the oncogenes are genes that turn the cancer on, and make them grow. CDH is basically, it's supposed to stop things from growing. And so in order to target it, you need to figure out a way to reactivate it. But I think, that you make a great point. The Claudin 18.2, there's a lot of drugs being developed in that area. Both, I think there's some antibody drug conjugates coming down the pike in the future, but right now, some direct antibodies to it as well as the CAR T. Any other questions?
Yes, we actually have another question. Are clinical trials covered by insurance? And what if it requires me to have to travel? Would that be covered as well?
Dr. Nguyen, you want to answer that, or?
Yeah, well, it's if it's a new drug that's not FDA approved that a drug company has and sponsor, so that's the one that is covered. But if it's using a standard of care drug, at least in our institution, is the insurance pays for it. And unfortunately, travel is not covered. It's not covered by, at least from the clinical trial sponsored drugs or the corporate groups. It requires patients to make their own arrangements to travel to the site to get the treatment.
Okay, I'm sorry, there's like a scraping noise from someone's
Yeah, there's a scraping noise. So yes, a lot of people have clinical trials covered on their insurance. There are some insurances that don't do as good a job of covering. And of course, there's sometimes when your insurance doesn't cover the location where the trial is being done. Travel can be covered at times. It's not automatically covered. And if it's covered by the drug company. We do try to negotiate that in our contracts because we have a lot of people who travel to our institution for trials. But it's often not nearly as much as might cost to travel if you have to go, and stay overnight and things. But we do try and get as much coverage as possible. But it's not something that insurance would cover for clinical trials. Most of our patients have clinical trials insurance coverage, and in fact, over the years, both parties have supported additions to Obamacare and other laws that have increased the coverage that Medicare is supposed to do, and that has forced other insurances to cover more. Does anybody have anything different or something else to say to that? Because that's about as much as I know, and that's there are rules by state as well, but I can't go over all 50 states, nor do I know them.
Yeah, the only other thing that I would add would be typically what I tend to do is have my coordinator, once the patient's interested in a clinical trial, especially an out-of-state or out-of-town patient, have them meet with the patient financial services and actually split up the whole thing in terms of what their co-pays are, what is covered by the sponsor, what is covered by the insurance company, and then patients actually have all that information to make that informed decision in terms of whether that's feasible for them or not. So that way you know upfront what you're dealing with, as opposed to being surprised with a sticker bumper, whatever shock.
Brittany, any others?
The last one is, how do I find clinical trials if I'm interested?
So one site to go to is the ct.gov site. Does Debbie's Dream help people find clinical trials? I would think that would be the ultimately best place to go.
The best place to go would be the Debbie's Dream Foundation website. That's debbiesdream.org. And under resources, you can click on clinical trials. We do have a clinical trials matching program that once you input all of your information, it will find the best match for clinical trials available to you.
Right, and theirs would probably be more specific. The ct.gov tends to get a lot of trials that you're not actually eligible for or don't really affect you. And, of course, your doctor can always be a great reference as well, but Debbie's Dream Foundation is here for you. And that's what's really cool.
So if that concludes our discussion today, I would first like to thank our panelists. You guys were awesome, amazing. We really appreciate your expertise and your time. I'd also like to thank our sponsors, title sponsors Merck, platinum sponsor Astellas, Daiichi Sankyo, Zymeworks, gold sponsor Bristol Myers Squibb, and bronze sponsor Seagen. For anyone interested in our upcoming events and programs, you can visit our website at debbiesdream.org. As you can see some of our highlighted events, we have our stomach cancer support groups, which take place on the first Thursday of every month. Our Holiday Meals for the Stomach Cancer Patient webinar is a live cooking demo on Facebook Live. We have a webinar on December 8th, Talking to Your Kids About Cancer. We also are gearing up for our 10th annual Stomach Cancer Capitol Hill Advocacy Day. That's one of our biggest initiatives, and that's February 7th through 9th. If you want to get involved with raising awareness, November is Gastric Cancer Awareness Month. We have coined the term Curing Stomach Cancer Month, so you can have your state declare November as Curing Stomach Cancer Month. Visit our website for simple step-by-step details on how to do that at debbiesdream.org. And that concludes our presentation today. Once again, thank you so much for your time, and we'll see you next time.
Thank you, Brendan. Thank you.
Thanks, everybody.
Bye-bye.
Thank you all. Bye-bye.
Bye.